So if we change treatment, how long will it be until we know whether the new treatment is working? And how will I know if my symptoms have improved as much as they're going to?
The first way to tell how long we're going to need treatment and if it's going to work is to first confirm that the disease is active. Second, with blood testing. Second, to confirm that the symptoms, signs, and as well as the laboratory abnormalities are associated with lupus. In other words, let's say your thyroid's off, or let's say it's due to another, let's say you're diabetic, let's say the diabetes is out of control. So the first way to test to see if it is indeed the lupus is to give a drug such as a corticosteroid or prednisone that works in a day or two for just a few days to confirm that it is the lupus that is active. Once you confirm that, different lupus drugs take different periods of times to work, and they can also be used in combinations. For example, hydroxychloroquine or Plaquenil takes 6 to 12 weeks to work. Methotrexate takes 4 to 12 weeks to work. Belimumab takes 6 to 12 weeks to work. Mycophenolate starts working in about 4 weeks. And azathioprine works in 6 to 12 weeks. And corticosteroids work right away, as I mentioned. So one has to try the medicine knowing how long it will take to work. One point is that even though some of these medicines may not peak in their effectiveness for 12 weeks, the side effects would be noticed immediately. So if you have trouble taking the drug and need to transition to something else, this readily becomes apparent.
I'm concerned about taking too many steroids. Is it really necessary to take prednisone? Because I don't want to gain weight, and I know they can cause osteoporosis.
Most patients take steroids sometime in the course of having lupus. It's about 75%, but only about 25% of lupus patients are on chronic corticosteroids. There are different thresholds of steroid damage, and it's been shown from several studies that if you can get below 5 to 7 milligrams of prednisone equivalent a day, usually the long-term side effects and toxicity is minimal. If one cannot get below 7 milligrams a day, that's an indication for adding a steroid-sparing drug such as methotrexate, mycophenolate, azathioprine, or belimumab.
Are there other treatments that can reduce the need for steroids?
All 4 of those are steroid-sparing drugs. There are specialized niche therapies. Let's say you present with low platelets, or let's say hemolytic anemia. In these circumstances, there may be situations where other steroid-sparing drugs are used for these specific abnormalities. They range from intravenous immunoglobulin to apheresis to other organ-specific measures such as cyclosporin or tacrolimus, rapamycin, and other agents.